For this EKG, you see it says rate, rhythm, don't worry, P wave. Uh, just so, oh, I forgot to tell Kat, but what you want, I want you to answer, don't worry about what it says there, okay? I just want you to tell me, you say there's a block, or you say ventricular tachycardia, or stuff like that, okay? You, of course, try and guess, no, estimate the heart rate, okay? Then you say, um, you can say sinus rhythm, normal, or you can say, I don't see a P wave. Just so I know that you understand the PQRS, you can say, I don't see the P wave. It's missing in whatever, in this, so you can use arrows, just so I know that you understand. So, and then you say, I guess there's a block. You can just write that one, okay? So don't worry about this one, okay? I hope you understand the reason why when we do EKG, you cannot just have a strip for maybe 2 seconds and that's it. Especially for those who have you ever felt sometimes you have skipped beats every so often? If you just did an EKG for 2 seconds, you will miss that skipped beat, which may be a trigger or precursor for maybe a clot or beginning AFib. So that's why we want a long strip. But this one is just giving you examples. Okay? So this will be your take home. The take home includes blood vessel and heart, combined heart, and then some questions again. Just very few questions. Then we're gonna this yes.
Is that due on Monday or Wednesday?
On what do you want? What do you want? Monday or Wednesday?
Monday's fine.
I think Monday should be
Yeah.
good
The whole
because
weekend.
you'll be packed. So okay. And then next week, I have a question for you guys. Next week we're gonna figure out why is it that when someone has a I'm gonna tell you. Okay, so we're talking about blood vessels now today. This is the last organ of your cardiovascular system, the blood vessels. So we started with the blood, then the heart, then the cardiovascular system. Did you say you have a problem with the cardiac cycle?
Yeah, I don't quite understand it.
Okay, what I will do with you then, we just do it, you and me.
Yeah, if you could just
You and I
explain.
do it.
Okay.
Or maybe we'll do it. Or
Okay.
are you all good on the cardiac cycle?
Yeah.
No, okay. So let's chapter 8. Again,
When you say cardiac cycle, you're talking the electrical cycle or the blood cycle?
the whole cycle, I think that's what they want to. Is it this one here? This one? Must be that one? Is that the one? Is this the one?
No, we didn't turn that in.
Yeah, is that is that what you need
Did we
to
turn
talk
that
about?
Possibly,
The
yeah.
cardiac cycle?
About the functioning of each part on that page.
Wait a minute, I didn't turn that in. Oh.
You mean this one? This one?
Yeah.
Okay, so I'm not gonna get in trouble if I didn't
Yeah.
turn that in?
So that's the one.
Because I didn't finish the
Explain.
back side of that.
Okay,
I don't-
so
People were saying that.
again, you start with this one. You have to keep looking at it and looking at it. Once you stare at it, once you look at it, one by one you start. Remember, see, when this, you see me trace it, you follow all the way. So,
And what does that represent exactly? I don't understand what it represents.
what does P wave stand for? What does P wave
The atrium.
depolarization, right?
Right.
So do you know the P wave, right? P wave is for what? Atrial depolarization. What does that mean? When the
I have no
atrium
idea.
The
gets
atrium's filling, right?
depolarized, it's going to
Fill.
no, it's going
Going to contract?
contract.
I thought it
Right.
contracted after the P wave.
It will contract after the P wave, but I said what happens after the P wave?
Oh, after, okay.
When it depolarizes, it will contract.
So after the P wave, the atrial
What does P wave mean?
depolarization, which means contract.
P wave is depolarization, right? What does depolarization mean? Stimulates, right? Then that means because this is atrial depolarization, that must mean after this one the atria will contract. So just imagine there's your right atria,
Okay.
left atria, right ventricle, left ventricle. We're going to start with all the valves closed, right? This is the aorta, valves are closed, and this is the pulmonary artery. Pulmonary artery, this is your aorta. So we start with all the valves closed, and we know that the blood is being returned. So as this is filling with blood, the P wave happens, it gets stimulated, right? Then it contracts. So when it contracts, what happens? The pressure goes up in the atria. So atrial pressure, see? After the P wave, see the pressure is going up, the green. The pressure goes up. And that pressure increase will then open this AV valves, right? To push the blood from here to here. It's the same thing that happens here. Okay? So when the blood goes down here, look at the volume of the blood in the ventricle is going up because the atria pushed the blood from the atria, it pushed its blood to the ventricle. So now the ventricle received the blood. And then in the meantime, the QRS, it just keeps moving, right? So this is, what does the QRS mean?
Depolarization of the ventricles.
Of the ventricles. So after the ventricles get depolarized, what do the ventricles do? They contract. So when they contract, look at the ventricular pressure. See, after the ventricular depolarization, the pressure of the ventricle goes up. Right? This blue one. When the pressure goes up, it will the pressure, it will eventually close this AV valves, which is what we hear, the first heart sound, right? And to the point where the pressure goes high enough to push now open your semilunar valves so that the blood goes up there. And then after that one, the ventricles go into diastole, they relax. So when they relax, the pressure here goes down. In the meantime, there's the elastic recoil of your arteries. So the blood, because the pressure goes down here, the blood has a tendency to go back down here. And that is what will close your semilunar valves, S2. So when the semilunar valves close, all the valves are closed again. That's the reason for this isovolumetric contraction and isovolumetric relaxation. Then another round. The only way to really master this one is you keep looking at it. Again, this one up here, this EKG. The EKG is nothing but a strip that shows you the progression of depolarization or stimulation of your muscles. The heart muscle. And you should know that when the heart muscle eventually contracts, it will cause differences in pressure. It increases pressure and pushing the volume from one chamber to the next. And that's why you see all of these, what do you call this? Lines are there? They're not lines. These waves. That's why you see this one. Okay? One more time, let's practice again. There's your P wave, the atria, right? The atria depolarizes. When the atria depolarizes, what happens again? It contracts. So when it contracts, what happens to the pressure in the atria? Look at the green one. See, it goes up, right? When it contracts, it goes up. It goes up to the point where it will finally open these AV valves to push the blood that it received, deliver it here. That's how they move, right? It's pressure related. So when the volume moved from here to here, what do you think will happen to the volume here? It will go up, right? So if we trace to the left ventricular volume, see, the volume in the ventricle went up because it received the blood that was in the atria. So then QRS, the ventricles depolarize. So eventually that will cause contraction of my ventricles. So when the ventricles contract, what happens to the pressure? It goes up, right? So look at left ventricular pressure. secondary to the QRS, the pressure went up. This blue one, see? When the pressure goes up, what will happen initially, the regurgitation will cause the closure of these valves, right? So that's what you hear as the first heart sound. And when the valves are closed, there will be a point where all the valves are closed when the ventricles are in systole. That's what you call isovolumetric contraction. And then to the point where it still goes up, 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 enough pressure to now push these valves open, the semilunar valves. Now the blood is able to go out of the heart. Okay? Then what happens after the muscles contract? They relax. So when this relaxes, the pressure here goes down. And then in the meantime, these arteries, remember, they have elastic recoil, so they will go back to their original shape, and the blood will have a tendency to go back down there. And that going back down of the blood will close these valves called semilunar valves. When they close, you hear it as your second heart sound. So you see, look at all the valves will be closed again. And this one was in diastole. So that's what you call you're not going to change the volume, right? When all the valves are closed. Isovolumetric relaxation. Then another cycle again. You don't let this picture scare you. It's not really, you take it maybe one at a time. You start with this one. Then you say, oh, this is atrial depolarization. I'm going to look at the atria. So you predict first in your head. What happens when it gets depolarized? It contracts. So I wonder what's going to happen when it contracts. I'm thinking the pressure in the atria will increase, right? It's receiving all the blood from the veins, so it will increase. Always you start with all the valves closed. So the pressure goes up so high to push open these valves. Then go from here to here. In the meantime, we go back. This is you stimulate again the ventricle, then it will contract, increase pressure here, close these valves, open these next valves, right? Push the blood out here. So after it contracts, relax.
What are those valves called right there, the two that they close?
It's called semilunar valves. Okay? The aortic and pulmonary valves. Okay? So just keep reading it. You can eventually tie it to this last one right here is just showing you really the direction of the blood over here.
And the second heartbeat is the closure of the aorta valve?
Second heart sound, right?
Is the closure of the aorta?
Of both the aorta and pulmonary artery. They're called semilunar valves.
So how do they open in between I'm confused with the
How do they open?
sound is the closure of those two valves.
The what?
The first heart sound.
It's closure of the AV valves.
Okay, so how do they open if the second heart sound, you have those two open, that one open, and now they close. So what happened? How did they open? I don't understand. You said they close.
So what valve are you talking about?
The semilunar valves.
Remember when the ventricles contract, they're going to open this one.
Okay.
Right? When the ventricles contract, look at the blood will regurgitate, and it will close this one, and it will open this one.
Okay.
And then when this relaxes, right, it pushes the blood there. Then it relaxes. So when it relaxes, all the blood here in the aorta will have a tendency to go back down there, right? Because of the elastic recoil. So the pushing of the blood back here will then close these valves here. So
now those two, okay.
Yeah, already. Now they close.
Alright.
So keep looking at it and looking at it. It's confusing. Even I was confused when I was studying way back in the Ice Age. But then I look at it, it's not that hard. Okay? You will understand it. Just remember, stimulate, contract, stimulate, contract. And what do? We start with all the valves closed. Start with all the valves closed, okay? And then start with all the valves closed and then begin with your EKG, okay? So, now we go to our blood vessels. So, here are your blood vessels. You have three general types of blood vessels. You have your arteries, you have your capillaries, and you have your veins, okay? Oh, one more thing before I forget. Don't forget that you cannot get more than 100% either in the lecture or the worksheets, right? Lecture or lab, right? Only one, some people I see 118%, 100. When it comes time to get the 75% and the 25%, it will only be no more than 100%. Does it make sense? Do you
Like
understand?
your final grade.
Yes,
class.
your final grade, right?
No,
Right?
so you can't get like a 4.8.
No, you can't. You can't. Okay, so here you go. So
I have
we
a
look at-
question.
Yes.
The last email that you sent us about the aortic,
Atrial natriuretic peptide.
that's going to be on the heart, right? The heart test?
Yeah, the
Okay.
atria.
Oh.
Yeah. Okay. So here, so you have three major blood vessels: the artery, the veins, and your capillaries. You should know A for away. The job of arteries is to deliver blood away from the heart. Veins in. They deliver blood back into the heart. And then the capillaries are the only exchange vessels. Exchange. So please look at this picture and you will need to remember this one, okay? Don't ever forget this. If there is any exchange, any kind of exchange at all between blood and tissues, it always only involves capillaries. Nothing can escape your arteries or veins unless there's a cut. So like we talk about your nutrients, the glucose, how from your GI tract, how does it enter my blood? Here. How do I release my hormones? Right? My endocrine glands make hormones and then they dump it into the blood. Where? Always capillaries. Because only capillaries have pores or openings. You don't have pores or openings in your arteries or your veins. Even the exchange of gases, right? The carbon dioxide, the oxygen, always think this one, okay? Water, whatever it is that involves any kind of entry-exit movement, capillaries, okay? So let's start with our um, arteries. So these are your, by the way, be able to differentiate. If you look at the microscope and you're asked to identify which one is an artery, which one is a vein, which one is a capillary, it's very easy. Veins are generally collapsible. Veins have a thinner muscle wall than arteries. Arteries maintain their shape, number one. And number two, if you look closely, arteries have an elastic layer. Okay, here, this one here. See that elastic layer, but this is a nicer view. You see, you remember the squiggly, the kinky, elastic fibers? Only arteries will have a layer of elastic fibers in its wall. And of the major arteries, I know you're familiar with the aorta, right? And the pulmonary artery. These are the two big arteries that come out of the heart. Does it make sense if I tell you that the aorta and the pulmonary arteries, they must be the ones with the most amount of elastic fibers? Do you agree? Because it is the one that receives the bulk of the blood that's being pumped by the heart, right? And remember what I told you, it would be nice for you to research where you find elastic fibers in the body to see where the damage of smoking is being is occurring right here. This is going to be damaged. Remember, smoking causes wrinkles because we have elastic fibers there. We also have elastic fibers here. And that's why smokers are at increased risk for aneurysm, number one. Also hypertension. It hardens. What's the function of elastic arteries? It enables them to expand, right? It's able to expand and receive all of that blood that's being pumped by the heart. It's the first one, right? Think aorta, think pulmonary. Is when the ventricles contract, they're going to deliver all of the blood that they receive to this one. Okay? So you have different types of arteries. You have your muscular arteries, your conducting arteries. But you don't need, I really don't. To me, what's more important is knowing the anatomical differences between arteries, veins, and capillaries, and understanding when they say arteriosclerosis, why that happens, being able to explain to your patients why smoking targets arteries. If they say it will harden the arteries, that is really the main reason. That layer of elastic fiber, it's called elastic lamina, okay? Arteries also have a thicker, smooth muscle wall than your veins, okay? So when you hear the terms vasoconstriction, vasodilation, so there's vasoconstriction, vasodilation. These terms always, unless it's specified, it generally applies to arteries only. Obviously, capillaries cannot constrict or dilate. If you look at this picture over here, I hope it's just one cell layer thick. Look at, because this is where exchange happens, right, in your capillaries. It must be difficult for exchange to happen if it's more than one cell layer thick. Don't you think so? So capillaries, look at, do you know what this is? Endothelium. What is that tissue type? It is epithelium. Any kind of exchange must be epithelium. In fact, capillaries have the thinnest type of epithelium, which is simple squamous epithelium. The thinnest, so that there's not too far for exchange to happen. Okay? So when you say vasoconstriction, vasodilation, obviously it's not going to be applied here, right? Because capillaries have no muscle. You cannot apply the term to your veins also, because the muscle here is very thin. They don't constrict, dilate. They collapse, but they cannot constrict, dilate. This one has a thick muscle layer. So, and it makes sense. If you think about the job of the arteries are the ones, really, that's very important in carrying on that pressure to nourish the rest of my body tissues, not the veins. The veins return the blood back to the heart. We're going to talk about how blood is able to return back to the heart if constriction does not happen in your veins. Okay? So, what I want you to know or to understand is, to know the names of the big arteries. You know that you have arteries, you have a deeper group of arteries also. All I want you to know are the big arteries. I want you to know the aorta. I want you to know that when it comes out, this is called ascending aorta, and then this is called the arch of the aorta. Then when it starts going down, this is called descending aorta. The descending aorta becomes thoracic aorta right here, and then in the abdomen you say it's abdominal aorta. Then from the aorta, know the immediate branches that come out of your aorta, which shouldn't be hard. I know you know your carotids, right? The carotid arteries. Then The immediate branches. What do you think? If it says splenic artery, where is that going to go?
Spleen.
Yes. If it says renal artery, where's it going to go?
Kidney.
Yes. So know those
Hepatic.
major, the immediate branches.
You have like a list somewhere on your slides?
Just the immediate branches. I'm going to show you in the cat.
Okay.
Then the last is the iliac artery. If we say femoral artery, where's it going to go?
Legs.
The legs, right? Okay. So then the smaller arteries, they actually don't have any names, but the immediate branches. Okay. I'm going to show you that in the cat. And once you know then when we study the digestive system, we say gastric artery. You know that it's going to the stomach. Okay. It's a branch of the aorta that goes to the stomach. Okay. You say celiac artery. It's a branch of the aorta that goes to your small intestines. Okay. So that's how we get the name of our arteries.
I have a question. Why, because I've actually had a patient ask me this and I didn't know the answer, why is the ABGs when they draw from the artery much more painful than when you draw from a vein? Is it because they're deeper?
The ABGs are much more painful in the arteries than in
Yeah,
the
because
vein.
they draw arterial blood gases from the
Yes,
arteries.
from the artery.
And
You
I've
can't
had
take it from the
patients,
vein.
yeah, say that it's much more painful than when they get just regular blood draws.
I have no answer for that.
I mean, is there
Because
more
I've never
nerves
had an
or?
ABG done on me, so I can't really tell. I don't know why.
Yeah, I couldn't, I couldn't find it anywhere, but I've had more than one patient say that they're way more painful
Is it
than
'cause
just
of
a
the muscle?
regular. Yeah,
That's
is
what I
it?
was wondering. The muscle and
It must
if you
be,
hit muscle,
because
it's very
they
painful.
get irritated. That's right, because they have a thicker muscle, so they must have a more extensive venous plexus than the veins. Must be. I can't tell because I haven't had it
Yeah, me either.
experienced any
I
ABG.
mean, what happens when they stick a needle in your arm and they hit the muscle? It's painful. So
Let's
I
look
would
at this
imagine.
vein. Okay? Okay. Can you
Arteries would be
picture
the
in your
same way.
head? The veins, okay? The veins, their job, they're supposed to return the blood. Look at this picture. So this is how the usual distribution of blood flow happens. Look at, from one artery, when it's going to distribute the blood, it distributes it into a bed. It's always referred to as a capillary bed. A bed, see? Does it make sense then that by the time, first of all, look at, think pressure, pressure, pressure. When the pressure is distributed, you predict the pressure when it finally collects here. I'm thinking it's going to go down, right? The pressure goes down right here. Does it make sense? Because you're going to spread the well, so then the pressure here goes down. Does it make sense, everybody? Do you understand what I meant? Right? So look at pressure in just one big vessel, then all of a sudden you spread the well. I'm thinking the pressure will go down here. So by the time the return of the blood happens in the vein, the pressure here in the vein is low. So I wonder what factors will help them. If the veins have a thinner blood vessel, thinner muscle wall, what factors will help in the return of blood back to the heart? I'm guessing gravity for the vessels above the head. Above the heart. For above the heart, gravity is going to be easy, right? To help the return of blood from the head back to the heart. Make sense, right?
And they have valves.
That's very good. For below the heart, if you look at your veins for below the heart, there are valves. And the function of valves is to prevent the backflow. But that is just all it does. It just prevents backflow. What will help push the blood up? That's the question. The answer is skeletal muscle contraction. This is why we tell our patients to keep walking, right? Be very, physically active, because, and I want you to prove this to yourselves. I want you to open up your cats next week and really find out if it's true that veins are always enclosed or squeezed or sandwiched by bellies of muscle. So when muscle contracts, right, it shortens and the belly will squeeze the blood going up. That's how, so you have gravity, you have valves, and you have skeletal muscle contraction. You see, that's only good for veins in your limbs, upper and lower limbs. What about the veins here? When it goes up here, you don't have skeletal muscle in there, right? Now comes the importance of breathing, right? When we breathe, you know the diaphragm? You familiar with the diaphragm? When we breathe, the diaphragm flattens, right? So if it flattens, what do you think is going to happen to this cavity right here? You're squeezing all your organs. You're increasing the pressure here, right? So that promotes in squeezing the blood to push it back up to the heart. This is why you want to encourage breathing and physical activity with your patients. One thing I want you to also appreciate is the anatomy of these valves. This is very important for us to remember. Look at the, do you remember the valves of the heart? I had you touch it, right? I had you feel it, how tough it is. It is tough connective tissue. If you take a look at this valve of the veins, can you guess what is the tissue type of this valve? Is it connective tissue? No,
Looks
it
like
is
smooth muscle.
epithelium.
Epithelium.
It's epithelium.
Oh.
It's scary, isn't it?
Oh.
It's just a modified fold of epithelium. So is epithelium strong as no?
No.
That is why, look at me, I have varicosities, right? Because it's
Varicosities.
you, the longer you stand, right, the gravity, because this is not actual connective tissue, it's just epithelium. It won't be, it's not as strong as your actual valves of the heart, right? Like when there's rain, eventually it will, if you have a tarp like that, doesn't
It'll
it
collapse.
eventually, what do you call that?
It'll collapse.
It collapses. Very good. Okay? You understand? And this is why there is a chance for pooling of the blood and a thrombus to form. You familiar with the word thrombus, right? It's a clot. You should understand the difference between thrombus. Oh, I know you know this, right?
And embolus.
Embolus, because we did this in our worksheet. Embolus is a clot that has
Moving.
moved. The thrombus is the clot that formed right there. So now do you understand why, let's say, truck drivers, when they're in that position for a long time, my goodness, just the fact that all this does is to prevent backflow. They cannot push the blood. It is the skeletal muscle contracting that can push that blood up, return to the heart. So when you're sitting down there driving for a long time in that position, are you doing any skeletal muscle contraction? No. So there is a chance for pulling, and that's why there's a possibility for a thrombus. And our next activity, we're going to tie why, when there's a thrombus, any part of the bowel, when there's a thrombus, which commonly happens in your lower extremities, why is it that we always worry about the lungs? Why is that the first target of an embolus? Why does it go there?
Because
in the
that's
lungs?
where the blood goes to.
We're going to talk about it. Very good. You're going to trace the blood vessel all the way, trace all the blood vessels. And that's a group activity we're going to do on Monday. Yes, what's your question?
I heard that when you cross your legs and you sit that way for a long time, that also causes blood clots.
The what?
When you cross your legs, sit cross-legged like this. For
Yes,
then-
it pulls. So this is what happens, right? Do you think that varicosities are dangerous? I think it is, right? Once you have a varicosity, you want to be always mobile. So that's why I'm always walking, right? You don't, because this is showing me. By the way, this is not my legs, just in case you want. This is showing me that there's already pulling over there. So you are at risk for a thrombus in the future. So just always be very mobile. I always look at Lily's legs, and you know how children are. It doesn't bother them when they're standing for a long time. I always think, lay down now, raise your legs. It's dangerous. So now you can explain to your patients, right, why it is very important to walk. It's just the valves just prevent backup. They cannot push the blood up. What will push it is the muscle. The muscle is the one that will squeeze it, the skeletal muscle here. And then when you get up here, okay, they push the blood up here. How is it going to return from here to the heart? Now the breathing is very important. You need to cause pressure in your cavities right here. It's a closed cavity, right? And then here, closed cavity. That's how you squeeze the blood back to the heart. Okay?
So if your muscles aren't contracting,
The skeletal muscle,
well, the
right
muscle,
here,
if it's not contracting, then it's not pushing the blood,
it's not. Look, yeah.
which
it's
can
not.
cause.
Yeah, so see, this
The
is
clot
not
to form.
contracting. So look at how we're going to push. What's
Thank
the
you.
function of the valve? Just to prevent backflow. But you have to squeeze, push, right? Okay. So what I want you to do, don't forget, I want you to look for that in the cat. Look for a vein. Just see if it's true. In my opinion, if you see it, it will stick to your head, and you can really tell your patients why they need to do this. You understand? Okay? Okay. So now we're going to look at, by the way, this is the normal flow of blood. The normal direction of blood flow is, I'm going to use this one, okay? This is your heart, okay? So the normal direction of blood flow from the heart to an artery, to a capillary bed, then vein back to the heart. Artery, capillary, vein back to the heart. Okay? So looking at this picture, can you tell me which one can control blood flow to a specific body part? Would it be the artery, capillary, or vein?
The artery.
Very good. The artery, right? So it can either constrict or dilate, right? The arteries, when they get smaller, the smaller arteries are called arterioles. Smaller veins are called venules. So the arterioles, right here, when they branch to the smaller ones, then they eventually become capillaries, right? This one, the arterioles, will have a wall of smooth muscle that becomes a sphincter. So you call it a precapillary sphincter, a sphincter. So they can either promote blood flow or they won't. There is sphincter. So let's say I am jogging, so I want most of the blood to go to my lower extremities. So then maybe, and I'm not eating. So I can channel some of the blood going to my GI tract to my legs. So the sphincter in my GI tract, I'm sure it's going to control the blood there, not too much, to channel blood to my legs so that it can get most of the nutrients and the oxygen as I exercise. Okay? Okay. Now, I want first to, and in addition to the normal flow, artery, capillary, vein back to the heart, this is the normal flow. Sometimes, have you heard of shunts? See, sometimes instead of the normal flow, it is possible that a capillary system, if like with dialysis patients, don't they do a shunt? They insert a tube, right? And so this becomes the artery, and then they shunt passing through a dialysis machine and then vein back to the heart. So you bypass the capillaries. It's okay. It's called a bypass, a shunt. This is just a picture of all the possible ways that blood circulates in the heart. In the body. Okay? So, it can be a shunt. It's also possible that from one capillary bed, instead of going directly, capillary vein back to the heart. This is the normal artery, capillary vein back to the heart. Like in your hypothalamus and pituitary. This is how it flows. So artery, capillary, then vein, then another set of capillaries before it goes back to the heart. This is called a portal system. You remember the hypothalamus and the pituitary? The hypothalamus secretes hormones and dumps it into the blood. And where is it going? Goes to the pituitary. Then the pituitary secretes hormones, dumps it into the blood. So this is an example of a portal system. You're going to remember this portal system when we study our liver, hepatic portal circulation. Anyway, this slide is just showing you that there's many different ways that circulation happens. It has to be many different ways because of the different functions, or let's say there's a dead part of the heart, compromised, MI, so you need collateral circulation. Then there will be a shunt. So there will be another way to nourish the other side of the heart. Okay, before I let you go, I want to talk about first hypertension. Okay? Hypertension. Our study is not finished yet, okay? So, you understand what hypertension means? And hypotension? Hypertension means your blood pressure is high. Hypo means, okay. So, I know that there's two numbers to a blood pressure reading, right? The top number, let's say 130, right? Over 80. Normal blood pressure, they say 120 over 80, right? So, what is this number? The top number is referred
Systolic.
to. Yes, systolic number, right? The lower number is called
Diastolic.
Diastolic number. Okay. So when you say, or when a patient, and it's always this way, right? The first to increase is always the systolic number. When you have systolic hypertension, the term systolic. So what do you think? Can you picture in your head where is the problem? I'm thinking if you have systolic hypertension, the problem is it's telling me that the ventricle has to pump hard to overcome a resistance. Does it make sense? Systole is when the ventricle contracts. So where is the problem?
In your
In
aorta?
the aorta, in the output. Very good. Did you understand that? The
No.
problem here is in the output. Again, when you say you have systolic hypertension, what does that mean? Systolic. It means the ventricle has to pump at a higher pressure. Why? There must be some resistance in the output. So the problem of systolic hypertensive patients is where? Arteries. This is referred to as arterial hypertension. Okay? And this is always what happens. This is always the beginning of hypertension in any of us. It starts with a systolic hypertension. And if we don't take care of that one, eventually this lower number also goes up. So this is referred to as diastolic hypertension, isn't it? Right? So what is diastole? Diastole is when the ventricles
You're
are
at rest.
at rest, relaxed. It needs to rest because it needs to what? Receive blood, isn't it? So when you say you have diastolic hypertension, picture in your head. It means that there is resistance in my, where's the problem? The problem is in the heart, isn't it? Right? The problem is in the heart. There is increased resistance in the heart itself to receive blood. This is telling me that my ventricles, remember the ventricles, the heart enlargement, the heart will eventually enlarge if there's increased resistance. Does it make sense? If there's increased resistance, the ventricles will eventually thicken. The walls of the ventricles will thicken. Remember? But do you remember? I told you to look at the pericardium as how it's locked in there. Is there a possibility for the heart to expand so that at least the space inside? No. So what will happen if the ventricle thickens, the space in the, so the ventricular wall thickens, the space becomes smaller and smaller. So you have diastolic hypertension. So if this is high, what's your problem? Your heart already. If only this is high, what's your problem? Just the arteries. Oh, well, it's not just the arteries,
Yeah.
but at least the heart is still okay. Do you understand these readings? Can you explain if I ask you? Explain this one, explain that one. Do you understand why it's called a silent killer now?
Mm-hmm.
You got it now. No, not too much.
Not
One more
on the
time.
diastolic. The systolic I can understand. but
Yes, okay. So when the systolic is high, right? That means the heart has to pump stronger. When it pumps stronger, what happens to the muscle? When you work out the muscle, what happens to the muscle? It increases
bigger.
in size, right? So when we increase the size of the ventricle, just like your muscle, skeletal muscle, when you increase the size of the ventricle, it's locked up in the pericardium. You increase the size of this ventricle. Right?
So the only way it has to go is in.
The only way it has to go is in. Yes, very good. Because the pericardium tightly locks it in there. You increase this, that's what's going to happen. The hypertension, you're increasing the size. So look at, the space gets smaller. So then there's going to be increased resistance to the blood return here. These patients with diastolic hypertension, look at their veins right here. It's thicker. They have bounding pulses. These are the patients with diastolic hypertension. These are the patients who can't sleep flat. They have to raise their, they can't. They
Those
feel
are the
that they're
patients that you can
drowning.
see their blood pressure without even using a cuff. You
Yeah,
could just watch
that's
it.
right. They because they feel, because see, there's, you see there will be backup of the blood, right, in the veins. Can you picture in your head, right? So they, in the lungs, and you can sometimes hear ralls. It's called ralls, like gurgling sounds in the lungs, because there's backup over there. Can you think you got it? Again, with systolic, where is the problem? Here in the artery, right? So look at, imagine, pump, 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 pump. Eventually, this gets thicker, right? It's working hard. So you make the hypertrophy, right? Hypertrophy, ventricular hypertrophy, right? But there's no space to expand that way. You cannot. So it's just gonna thicken and decrease the space here. So when the space decreases here, what's going to happen? You're going to resist the return of the blood there. When you resist the return of the blood, this goes up. You got a problem in your heart already. So for all of us who are hypertensive, we really have to be serious and take our blood pressure medication. We don't want this number to go up too. When this goes up, it's the heart. Now you have two problems, artery and heart. See you Monday, okay? I